Yes. Screen visible?
Visible, sir.
Yes, sir. Yes, sir.
Okay. Right. So complex regional pain syndrome is a form of debilitating neuropathic pain. So that is the description that should come in the first line itself. It's a complex, it's a debilitating form of neuropathic pain that may manifest following an injury or surgery, but it may occur later on. We will see in the type 1, it may occur without any injury or surgery also. So the other names, earlier it was called carsalgia, which is type 2, and reflex sympathetic dystrophy, and one more name is there, which is called algodystrophy. So because of the trophic changes, there is also another name called algodystrophy. So some quick static examiner, if he wants to teach you and use this as a short note question, describe algodystrophy, you should not be taken up by surprise. So remember that name also. And CRPS is a chronic pain condition that results in central and peripheral nervous system involvement, and it involves all the components, autonomic, motor, and sensory, and also causes changes in the skin and the nail and the hair and all that. That's called the trophic impairment. And the persistent pain and allodynia. All of you know what is allodynia. Pains perceived even for a non-painful stimulus or a non stimulus. So that impairs the quality of the patient. There are two types to go for the description. Type 1 is the absence of direct injury to a peripheral nerve, and type 2 is direct injury to a peripheral nerve, and that's why called as carsalgia. Then immediately go to describe the pathophysiology and treatment of CRPS. Both are almost similar only. So what are the postulated mechanisms for pathophysiology? One is central sensitization. That is, the nerves become hyperreactive, hypersensitized, which is called wind up. And there is alterations in the innervation of the affected limb. There are new nerve formation, just like angiogenesis, there is neurogenesis. So cross communications and new nerve formations are happening. So it is an electrical wiring becoming disorganized. Then there is a sympatho-afferent coupling. There is a the afferent pathway becomes sympathetic, and the efferent pathway becomes the sensory. So that is called the sympatho-afferent coupling. And there are inflammatory changes, and the brain also gets altered. The cortical plasticity of perception of pain, that itself is affected, and there are genetic and emotional factors. So remember these 6 factors as the postulated mechanism. Nobody is even now 100% sure as to why this is happening. So the points that you have to remember from examination theory writing point of view are the 6: central sensitization, alterations in the innervation of the affected limb, sympatho-afferent coupling, and inflammatory changes, cortical plasticity, and genetic and emotional factors. Now this picture describes how all these things take place. So this is the injured limb. Initial trauma is there. So depending upon the nociceptive density, you get increase in the inflammatory cytokines, interleukin 1B, 2, 6, CNS alpha, CGP, bradykinin, and all these things. And there is an inflammation and sensitization that is carried to the hair centers. And then over a period of time, what happens is there is a alteration. This blue thing shows that the cortical plasticity occurs, and this results in emotional arousal, limb presentation with chromatosensory changes, spinal cord sensitization, and genetic susceptibility also plays a role. Not that all of us who are going on surgery or undergoing a trauma do develop this. So there is a genetical cause for people getting this problem. And all these things resulting in stimulus from the adrenal gland. So catecholamine release is increased because of the constant pain, And that is the reason why the sympatho-afferent coupling happens, which results in expression of adrenal receptor on nociceptive fiber and upregulated adrenergic receptor sensitivity. So symptoms manifest following trauma or for any injury, and there is an atypical cross interaction between the motor fibers and the sympathetic and all these things, which release the inflammatory cytokines, which Prof described. And even though this is a disease of central nervous system, the symptoms are initiated in the periphery. That is one important thing factor about the characteristic of CRPS. The patients commonly report burning or pricking sensation. It is felt deep within the affected surface. So when you try to touch another, they are in the stage of allodynia. They may say it is paining, but their own perception of pain is always it is felt deep. That will be the Tamil description of these patients. So it is when they themselves touch their hand, they don't feel that much of pain. But the pain is constantly there. That means that is the common description, and it exists even at rest and increases with functioning of movement. And sensory abnormalities, of course, initial stages, they may have this allodynia and hyperalgesia, which is not confined only to the area of injury. So it may be happening even though they may have an injury in the finger. They may pursue the whole, the upper limb may be affected limb or the lower limb may be causing the pain. So it is not, that is another characteristic. So with all these clinical features itself, we have to diagnose because there are not many markers or any particular investigations which tell you that CRPS is there in a patient. So, and some patients feel it may be a neglect type of pain, and the limb feels as though it is not connected to the body in the affected area. And what are the trophic changes? As I said earlier, it may be happening in the hair, nails, or skin, and vasomotor, pseudomotor alterations cause changes in the skin color, sweating, and temperature. And there may be edema and cutaneous vasodilatation when the pain starts as an acute condition in the initial stages. But in chronic conditions, there is vasoconstriction leading to fluid discoloration and temperature drops because there is no blood flow and the limb becomes cold. Now, this much of description for a short term question may be sufficient so that you can finish it much faster also. And coming to the management, specific treatment protocols are not yet defined. So treatment modalities include, you can remember the names, it is more or less given in the alphabetical order. So you can try bisphosphonates, which are causing resorption of the bone resorption takes place in these patients. So that is the reason that is another added factor for the pain. So in order to strengthen the bone, bisphosphonates can be given. They are administered orally, and botulinum toxin A is also given, which again helps in the same way. Calcitonin again strengthens the bone. The carbamazepine, gabapentin, they are all anticonvulsants, which are normally given for any neuropathic pain. And intravenous immunoglobulins are given to modify the genetic nature. And they have tried another drug called lenalidomide, which is an analog of thalidomide. Okay? Thalidomide was given in children days in 1935. Lot of babies were born with congenital anomaly. They were called thalidomide babies. So this is another drug which is an immunomodulatory drug, and morphine for pain relief, and NMDA receptor vitamin for again pain relief, NSAIDs again for pain relief, and this tarforelate hydrochloride. This is a new drug which has been tried, which this is a 5-hydroxytryptamine 2A 2B antagonist, just like your ondansetron. This drug has been found to be useful in reducing the vascular changes and acting against the endothelial growth factor. So that drug also has been tried. And of course, you can give sympathetic blocks as he mentioned, stellate ganglion for upper limb and lumbar sympathetic block for lower limb can be given. And another new drug they have tried is tadalafil. What is this drug used for commonly? Any idea?
Pulmonary hypertension, sir.
Yeah, it can be given as a drug for pulmonary hypertension, but more commonly,
Sildenafil.
what
Erectile
was it
dysfunction.
introduced for it?
Erectile
It's a
dysfunction.
phosphodiesterase 5 inhibitor, and it was introduced as a
Erectile dysfunction.
erectile dysfunction drug for diabetic patients. Okay, just like your Viagra, which is this is tadalafil is the next generation to that. And this causes a good vasodilatation in chronic cases where vasoconstriction and bluish skin edema, temperature loss occur. This drug has been tried as to improve the vascularity. And adjuvant therapies like mirror therapy, physical therapy, and TENS, all these things. So you can see so many drugs have been tried, which means that there is no particular effective one drug or one treatment. So you have to go for multimodal approach and try to. And as we said, that 4 P's also is a good way of writing the answer, where you can classify them into patient education, physical therapy, pharmacological therapy, and psychological therapy. So that way also it will be a good presentation. So, so this is how, for those who have not seen a clinical case of CRPS, of course, in our people with the dark skin, it may not be appreciated very much, but in the Western, you can see the right limb is the acute one. It's redness, it's a normal one. You can see all the veins coursing here. There is good edema here. And if it is happening in the hand, again, you can see the edema and the redness. And this is the normal hand. And this is a comparison between an acute one and a chronic one. You can see the difference. This acute one is pinkish and blue, swollen, whereas this is classically bluish, like a sinus limb. And so you can differentiate between an acute and chronic by these pictures. Okay, so this is what I just wanted to share with you.